Okay, good afternoon everyone. Welcome to today's Active Adults Health and Active Lifestyle Scrutiny Board. Thanks for coming today. My name's Andrew Scopes. I'm the chair of this Scrutiny Board. I'm a councillor for the Beeston Holbeck ward of Leeds. Today is the sort of first business as usual scrutiny meeting for this board this year, of this municipal year. We obviously had the call-in meeting last week, and so that has taken one of our agenda items off because we've already appointed a co-opted member for the year. Okay, so I'm going to start with some introductions, but first I just need to let everyone know that this is a formal public meeting. It is being webcast, and it will be recorded for the public's to look at later. If you are a member of the public, you can put into any search engine Adults Health and Active Lifestyle Scrutiny Board Leeds. It'll be one of your first links for the papers that we are looking at. So we're going to start with introductions. So as I said, I'm Andrew Scopes. I'm the chair and I'm a councillor for Beeston Holbeck ward. We're going to start with board members. We'll go around board members and then we'll introduce guests when we get to the right place. So start this way. Thank you.
Thank you. Councillor Stephen Holroyd, Ardsley and Robin Hood ward.
Thank you, Chair. Councillor Bromley, Horsforth and Rawdon ward.
Good afternoon, everyone. Councillor Taylor for Chapel Allerton ward.
Good afternoon, Councillor Kevin Ritchie, Bramley and Stanley ward.
Good afternoon, Councillor James Gibson. I represent Crossgates and Wimore ward.
Good afternoon, Craig Timmins, Councillor in Carvely and Farsley, and I am substituting for someone today.
For Councillor Fransmere.
For Councillor Fransmere.
Good afternoon, I'm Jane Mashenko. I'm one of the co-chairs of Health Watch Leeds.
Good afternoon, I'm Councillor Sandy Lay, Otley and Yeadon ward.
Good afternoon, and Councillor David Blackburn, Farnley and Wortley ward.
Good afternoon, Councillor Lynn Buckley, Alwoodley ward.
Good afternoon, everyone. I'm Councillor Caroline Anderson. I represent Adlon Wharfdale ward.
Good afternoon, I'm Angela Brogden, the Principal Scrutiny Advisor to the board.
Super, thank you very much for that and welcome to today's meeting. I'm going to ask Angela just to run through the first 5 items, please. Thank you.
Thank you, Chair. In relation to item 1, there are no appeals against the refusal of inspection of documents. In relation to item 2, there are no items for exclusion of the public. In relation to item 3, a summary note of the Scrutiny Board's working group meeting on tackling obesity and supporting healthy weight has been circulated as part of a supplementary agenda pack, and this is in relation to agenda item 11. And under item 4, at this point, please can I ask members to declare any interests in accordance with the Council's Code of Conduct. And I shall take silence as none. Thank you. In relation to item 5, we have apologies from Councillor Fransmere and Councillor Timmins is in attendance as substitute member, and we also have apologies from Councillor Arif as executive member. Just make sure title for adult social care, active lifestyles and culture. Thank you.
Super, thank you very much. Okay, we're going to move on to the minutes. So we've got 2 sets of minutes to approve. Firstly, the previous board's minutes. And so I'll take any points of accuracy. Yes, Councillor Buckley.
Yes, can I just say, page 10, Community Mental Health Services, it says it was agreed that further benchmarking data relating to the services will be provided to board members and the longest waiting list service. I don't know, I haven't received anything. I don't know if any of the other members of the Scrutiny Board have.
Can you respond?
Try again. Thanks, Councillor Buckley. Yeah, under matters arising, I was going to say there's quite a number of follow-up information to do with mental health, but the idea being, particularly if we've got new board members as well, we're going to sort of, it's going to culminate in a fuller briefing note rather than come piecemeal, so that will be followed up. Okay, thank you.
Super, thank you for that, Councillor Buckley. So I'll take that as you're happy with the content, just not necessarily the matters arising, yes? Okay, so are we happy to approve those minutes? Okay, and then the second one is the call-in minutes, which is more recent. Because it is a formal meeting, are there any points of accuracy that anyone wants to raise in the call-in minutes? Because it was a decision made, I'm going to ask someone to propose those minutes. Who was at the meeting? Yeah, Councillor Bromley, and can I have a seconder? Councillor Ritchie, thank you very much. So those are approved. So that is good. So just moving on to matters arising. So over to you, Angela. I think it's just worth highlighting again the time frame we're hoping for the mental health feedback to come to us. Thank you.
Thank you, Chair. Yes, so that will be followed up obviously in the next few weeks to circulate to board members. Obviously, once we discuss the work programme, once we've had that briefing, if members feel that they would like that to come back as a formal item, then obviously we can arrange that as part of the work schedule as well.
Super, thank you very much for that, Angela. Okay, any other matters arising from board members? No, great. Okay, so I'm going to move on to item 7. So this is the scrutiny terms of reference, which I'm going to assume is read. So the recommendation is that members are requested to note the terms of reference as they relate to the scrutiny board. Are there any objections to that? I take silence as agreement. I'm not sure we can change them anyway, so it's quite handy to agree to them. Okay, so then moving on to item 8, I'm going to ask Angela to introduce this item.
Thank you, Chair. So this report really highlights that this scrutiny board has been assigned to fulfil the Council's statutory health scrutiny function. So this report presents information and guidance to assist the board in undertaking this role. Just to highlight some key elements, so the report specifically references the impact of the Health and Care Act from 2022, the substantial changes that were introduced from that Act in terms of the organisation of health and care functions across England, as well as the impact that it had on the role of local authority health scrutiny, which is set out in revised national guidance that was published back in January 2024, and there is a link to that guidance within the report itself. The report also makes reference to the duty of NHS commissioners and service providers to consult local authorities through their health scrutiny function, where any proposal is under consideration for a substantial development of the health service or a substantial variation in the provision of such a service in the local authority's area. So to assist in this process, a health service developments working group approach has previously been established to offer an environment that allows early engagement with the scrutiny board regarding proposed developments or changes to local health services. So it's therefore proposed that these similar arrangements are established again for this municipal year, and you'll find draft terms of reference appended to the report relating to the working group approach. So therefore consideration and agreement. The report also refers to joint health scrutiny. So again, under the existing health scrutiny regulations, there is a requirement for local authorities to appoint a mandatory joint health scrutiny committee where an NHS body or service provider needs to consult more than one local authority about a substantial reconfiguration proposal. So under these regulations, local authorities may also appoint a discretionary joint health scrutiny committee. So members' attention is therefore drawn in the report regarding the role of the West Yorkshire Joint Health Overview and Scrutiny Committee, which we often refer to as JOSC. That was established back in November 2015 as a discretionary committee, and the membership of this committee currently consists of 2 members from the relevant health scrutiny committees within each constituent local authority. The Leeds representations have generally included the chair, but also another member from this specific board. So as part of this item, members are also asked to formally appoint the board's representatives onto the West Yorkshire JOSC for this municipal year. Thank you.
Super, thank you very much. Firstly, are there any questions on any of that? I can't see anyone indicating. So in terms of the JOSC, what we've historically done is we've had the chair and one opposition member. As Angela already said, it's not a formal voting board, and so it's not got the typical political weightings that you might normally expect in sort of formal decision-making boards. I'm going to propose that myself and Councillor Lay get nominated onto that board, and Councillor Beckham's second that. Anyone not happy with that? I'll take that as agreement. I didn't see that, Councillor Lay, so it doesn't count. Okay, so that is agreed, and then the further recommendations are noted in the report, but I think they are as read, and you've read your papers, so good. Okay, so now we're going to move on to the sources of work, and this is a really important item for us. So at this meeting each year, we talk about what we want on our agenda, and it's really important to get the right balance between the various things that we look over. So I tried to tot it up last year, and I think we technically oversee over £2.5 billion of annual spend in the Leeds City region. Obviously, we can't look at all of that. And also, the other thing I think that's important is to make sure we leave space in our schedule in case something urgent comes up. And so it isn't a straightforward task. But one of the things we do each year in the source of the work item is we invite several of our partners to say what they think's important that's coming up and where they think we could add value. And then once we've listened to them, we're going to I'll open up to questions or comments from board members about what they want to talk about, or if there's anything that's been said that's particularly resonated with them. The only thing I'd add is that I've asked the ICB to give a little bit more detail than everyone else, and that's primarily because of the significant changes that are being required of them by the Department for Health. So that's why they've got a little bit more time, and that's why they've got slides, whereas everyone else is given an update. So I think what I'll do is I'll bring them in last, if that's okay. But before we go on to that, I'm just going to go round all the guests and ask them to introduce themselves, and then I'll bring in people as we go round. So, okay, I'll start with Councillor Venner, please.
Hi everyone, I'm Councillor Fiona Venner. I'm the Cabinet Member at the Council for Equality, Health and Wellbeing, and I chair the Health and Wellbeing Board.
Hello everyone, I'm Victoria Eaton. I'm the Director of Public Health at Leeds City Council.
Afternoon, I'm Stephen Baker and I'm the Head of Active Leeds for Leeds City Council.
Hi everyone, I'm Nicholas Anderson. I'm the Director of Nursing at Leeds and York Partnership.
Good afternoon everyone, I'm Shona McFarlane. I'm the Deputy Director for Adults and Health in Leeds City Council.
Good afternoon everyone, I'm Sabrina Armstrong. I'm Director of Partnership and Operations at the NHS West Yorkshire Integrated Care Board, but in Leeds.
Hi everyone, I'm Jason Brock. I'm a GP by background, but I am also the Medical Director in the Leeds office of the West Yorkshire ICB.
Hello, I'm Sam Prince. I'm Director of Operations and Deputy Chief Executive at Leeds Community Healthcare.
Good afternoon everybody, I'm Caroline Barrier. I'm the Director for Adults and Health at Leeds City Council.
Good afternoon everyone, I'm Kash Ahmed, Deputy Director for Integrated Commissioning, Adults and Health.
Super, thank you very much and welcome to today's meeting everyone. I appreciate you taking the time to come. So I'm going to start with Adults and Health and Caroline. Thank you.
Thank you very much. So I've got 4 items that it would be really helpful to have on the agenda for future Scrutiny Board, please. The first of which is the outcome of our CQC inspection that was undertaken the week of the 19th of May. We don't anticipate that we'll get the outcome of that until late summer, probably early sort of September time is anticipated. So as soon as we can schedule it in, we anticipate that there will be some areas that they will identify where we need to do more, part and parcel of an improvement programme, and I'd like to bring that here for discussion on areas that we would want to focus on in the next year or so in terms of our continuous improvement journey. I'd also like to bring together with our NHS partners, if that's okay, a joint report on the work we're doing around Home First, and this is phase 2 of the Home First programme around our proactive and prevention programme, which is just commencing underway. We've already got on the schedule and on the forward plan the community health and wellbeing pilot work with regards to home care. I'd like to bring a more rounded report on all of home care and our future commissioning or recommissioning of home care with the community health and wellbeing pilot as part of that discussion. And finally, we've also got carers as a matter that you wanted to put on the forward plan. So very much would like to bring a report and probably, again, a joint report with our NHS partners as well on what we're doing around carers and support to carers. Thank you very much.
Super, thank you for that, Caroline. Okay, I'm going to bring in Victoria next from Public Health. Thank you.
Thank you, Chair. There's probably 3 items I'd flag, but one of them is already on the forward plan, which is the annual Director of Public Health report. So I think that's on in the plan for September. So we've got that in already. That's important. We have a new drug and alcohol strategy for the city. Which takes a much broader approach from prevention right through to recovery. So that might be something the board would be interested to look at. It is a pretty significant piece of work, so I'd certainly recommend that. And then I guess there are examples where there would be a public health element of another discussion, but it wouldn't necessarily be led by public health. So, for example, we're doing new work around supervised toothbrushing for children in particular communities of the city, which is a new development, but it's part of the conversation around oral health and access to dental health generally. So I definitely suggest that whenever we bring the dental health, oral health update back, that we can make space to feedback on that supervised toothbrushing programme, that would be really helpful. Thank you.
Thank you very much, Victoria. Okay, I'm going to bring in Steve next from Active Leeds. Thank you.
Thank you, Councillor. I guess there's a couple of kind of work areas for us. One of those is how we kind of really embed our kind of physical activity ambition kind of work and all the good kind of practice that we've had through that, but really amplify this and make sure it's aligned to the kind of city ambitions in terms of the 3 pillars and how we can make sure that physical activity is kind of embedded into all 3 of those different areas. Obviously, it's quite easy to do from a health and wellbeing perspective, but from a zero carbon and inclusive growth, we've got some strong attributes as part of that work that we can interrelate back into that kind of city ambition. So there's a piece around that work about how we amplify that in greater detail. And then aligned to this, we currently have a new kind of funding application that we need to submit to kind of Support England to carry on our place-based kind of work, which is currently our Get Set Leeds local work. But there will be the expansion of that within this kind of funding application and how we do that and what we look at, along with the different areas that we could kind of coordinate as part of all that. So the 2 are kind of aligned on that front. But then secondly, in terms of active travel, we've currently got a kind of pilot with a DFT in terms of social prescribing, how we use active travel to kind of help us support that kind of area. But that comes to an end next year. And again, it's how we learn from that work and how we embed that across the piece without that needing that huge amounts of funding behind it to kind of spearhead that and how we do that better. Thank you, Chair.
Super, thank you very much. Okay, I'm going to bring in Sam next from Leeds Community Health.
Thank you. So 3 suggestions from me. The first is around neighbourhood health. And as we develop our model in Leeds, I thought Scrutiny might be interested to see that, particularly in terms of our prevention work that Caroline's talked about, proactive care, the work to stop take community services and its relationship with Home First. The second was around waiting lists, and we've had lots of conversations about waiting lists here at Scrutiny, but I wondered about doing something with an equity lens to look at both access and outcomes from an equity perspective. And the third one was around all organisations are obviously working on their cost improvements. We call that quality and value in our organisation. And again, I'm often concerned about individual organisations having their own CIP to meet and what that means for particular groups, because we don't always have eyes on what's happening elsewhere in the city.
Thank you very much, Sam, for that. Okay.
Which CIP?
Cost improvement programme, I'm sorry.
Thank you.
Thank you for that, Councillor Ritchie. Okay, I'm going to bring in Nicola from the Leeds York Partnership. Thank you.
Thank you. So we have a number of priorities, but I think three of the main priorities would be our work around our mother and baby unit. So we're extending our offer to increase the amount of beds that we have available for people in Leeds and West Yorkshire, for mums who've recently delivered babies and then become mentally unwell as a direct result of that. So some work ongoing over this year and next year to stand up those services. Potentially a full review of our inpatient services across Leeds for people with an SMI, that looks at reducing our length of stay, amount of time people stay in hospital, and our workforce around that. And then another area I think that would be of interest are around our A&E waits. So again, another big piece of work to look at reducing waits for people with severe and enduring mental illness who attend A&E, and then the prospect of specific mental health A&E services that the government have announced earlier this month.
Super, thank you very much for that. The eagle eye among you will notice that we haven't had Leeds Teaching Hospital Trust. Phil Wood was meant to come today, but they are in the middle of a CQC inspection, so he sent his apologies. I will talk to him separately to make sure I get anything from him. I'm happy to feed that back in an email if board members, when I say I mean Angela, is happy to send a note of what he said to you. So that's good. And then I've got it here, in fact. Do you want to just run through what he said in our call?
Thank you, Chair. This may come as part of the ICB sort of presentation, but he kind of, in terms of the development of the neighbourhood health approach and model in Leeds, I think that's a priority for sort of all NHS partners and providers, and also confirmed that Phil will be at our July meeting, and they'll be bringing a report in July regarding its recent CQC inspection of maternity and neonatal services. So that will be part of the July's meeting.
Thanks for that, Angela. And then on to Sabrina and Jason for the ICB. I don't know, are you going to put the slides up, Angela? Thank you.
Thank you, Chair. Slides.
Just bring this microphone a bit closer to you, Sabrina. That'd be helpful for us to hear you. Yeah, just bring it as close as you like. Yeah.
Is that better? Do you want to move? Thank you. Brilliant. Thank you. So I guess the things that we're suggesting that we bring in 25-26, some of them have already been covered, like the neighbourhood health, so I won't dwell on that. But we're giving you an update, a short update today on the changes to the NHS, but we thought sort of come September time we'll have more clarity, and it might be good to come back and give you a little bit more detail on the ICB proposals and the proposals for the Leeds Provider Partnership. The NHS 10-year plan is due to be published in the next few weeks. Again, we'd want to look at perhaps doing some analysis on what that says and what it means, and bring that September time-ish, if that fits with you. Elective care, looking at where the waiting times, I think Sam's already mentioned those, but also what the challenges are for us. Urgent and emergency care, we've recently had an urgent and emergency care plan published, so bringing you an update on that. Access to primary care, feedback on where we are around neurodiversity, and then perhaps in sort of December, January, bringing something around the financial planning for 26-27. So that's what we were thinking of in terms of suggested items. In terms of the the changes within the NHS. So you may recall that on the 13th of March we had some unexpected announcements around the merger of NHS England and the Department of Health and Social Care with a view to a 50% reduction in staff. And at the same time it was suggested there should be a 50% reduction in those in integrated care boards, and that to be done by Q3, so by the end of December this year. On the 2nd of May, the ICB model blueprint was published, so we've been able to now look at that in terms of our plans. And on the 30th of May, we submitted some proposals to NHS England on how we will reduce our workforce over the coming months to meet that target. They weren't structures; it was very much a narrative and around the functions that we will continue to deliver. So the next steps for the ICB or the Integrated Care Board. So we've got some staff planned across summer and early autumn. Can't give you exact dates yet because that's still being worked out. We'll be looking to appoint to the roles within the new operating model for the Integrated Care Board across the autumn and early winter, with a view to the new operating model being in place sometime between January and April next year. In order to do some of the changes, there needs to be some legislative change, and we're expecting that in autumn 2026. If that goes ahead, then it's expected that some functions will transfer out of the Integrated Care Board during the financial year 26-27. So that's the timeline for you. Next slide, please, Angela. Thank you. In terms of the model blueprint, you will note we haven't got a great deal of information to give you at the moment because a lot of this is still being worked through, but we'll give you what we can. The model blueprint basically had three components to it. The fact that it wanted the Integrated Care Board to be a strategic commissioner and develop that capability. So there were three areas. One was called Grow, or areas that we'll invest in over time. The second was where we will retain functions, and the third was around where they expect us to transfer functions out of the Integrated Care Board. So on the right-hand side of this slide, you can see some of the strategic commissioning functions that we're expected to deliver in the future around population health management, strategy and strategic planning, some core pay functions around contracting, utilisation, resource allocation, etc. Health inequalities and inclusion expertise, really important there, and commissioning of neighbourhood health end-to-end pathways, etc. Next slide, please, Angela. We're expected in time, whatever in time means, to transfer some functions to the providers. Now, by providers, we don't just mean NHS providers. It could also include organisations like the local authority or other organisations. So it's not just about the Integrated Care Board. Things that they're expecting us to transfer out will be things like local workforce development and training, digital and technology leadership, the development of neighbourhood and place-based partnerships, although we'll have a role in commissioning that, primary care operations, and a number of other things. But there are also areas that they're expecting to transfer out, but it's not clear yet where they would be transferred to, and they would require legislation. And those are safeguarding, SEND services and all-age continuing healthcare. Jason?
Okay, so there's a lot of information on this slide, and I'd rather we just used it as a bit of a summary, because it's really easy to get bogged down in quite a lot of technical phrases that, to be honest, haven't necessarily been that well defined either locally or nationally at the moment. But I think when you listen to the Secretary of State for Health and Social Care last week in his talks at NHS Confed Expo, you get an idea of what the overall ambitions of this change are. And effectively, it's to try and create a more permissive environment in places around providers to do the things that they need to do with their resources to improve care for local populations. And within that, not just increasing that permissiveness, but understanding that actually the accountability for some of those decisions sits more firmly in the provider space, whereas in the past it might have sat in a commissioner space. And what that means is that as they transfer functions over, some of that capability and know-how needs to be transferred over into that provider space as well. So with all the assumptions and caveats around the capabilities and the type of functions that are described on this stage, what we are hoping to do in West Yorkshire is that although the commissioning organisation, the ICB, will become smaller and be focused around those functions that it's going to retain and grow in the future, we are also hoping to develop a place-based presence that helps the providers and the place and local authority, etc., to start maturing and have some of that capability that's traditionally been in the commissioner space to help it take on those future responsibilities in the future. And so those integrated teams, how those things listed in yellow in that bit in the middle, which are focused around actually what do we really need here? What's the local insight? How do we plan locally to make sure we're doing and concentrating on the right things? And actually we've been doing a lot of that for a number of years with a really strong partnership in Leeds. How do we create the new ways of delivering care and services around neighbourhoods? So there'll be a really strong emphasis on being able to support place do that. And how do we make sure that all the incentives, the management of risk, the transfer of that between organisations supports doing the right thing, then rather than creating what has often been the case in the past, some perverse incentives. So I think it's really important for Scrutiny to really focus on what is it that we are going to have in Leeds. Is it going to be fit for purpose to help us as a partnership be able to deliver the future that we see as being important? And I think I'll leave it there rather than getting too technical.
Super, thank you very much for sharing that information. I'm going to start with questions on the ICB. If anyone wants to ask questions, I'm going to bring in Councillor Lay.
Thank you, and thanks for that. Can I just ask, I know you don't know much yet, because it's a very fast changing, but will this create fragmentation across our providers? Where will the oversight and scrutiny, will it sit here in this scrutiny board? Because the NHS, well, the ICB and the the wider NHS talks about having joined up systems, etc. And I think of digital and the ability for, my mother to come to Yorkshire and have her record seen, even though she lives in Norfolk or whatever. Yeah. Is this a step in the right direction for that joined up stuff? Because it feels like we're breaking the system up again.
I think it's a really, really good question. I think at the heart of that there is always that difference between what's necessary to make sure that you have a high-performing place versus the imperatives of a national health system. And so there's always going to be a degree of a fragmentation somewhere. I think the overall ambitions and where we get to, who knows, we've been through loads of changes and they all come with benefits and risks associated with them. But the idea to create the local freedoms to be able to be as good as you can be to focus on local health inequalities and local need has to be a positive point. And in terms of scrutiny of what we are delivering for the people of Leeds, actually having more of that accountability and power in the future in a provider partnership has to be the right way to go. In saying that, you're absolutely right. There are some infrastructure requirements which the NHS isn't very good at, but it does make sense to do at a larger scale. And I think those are some of the things that they're working through at the moment in these rapid discussions. So the type of question you're asking is the type of discussions that we are seeing happening around us all the time at the moment. And there are some projects that fulfill some of the things that you're describing that we won't go into now, but it is something that we should keep an eye on because it will have a local impact.
I just want to I think people don't realise just how much comes from the top down to the shop floor, to the clinical environment. Most people know that I'm a nurse and I work in Harrogate. I wander around the hospital, and this is a couple of years ago, but I wander around the hospital and I see signs saying clean hands, etc., what you would expect. But then I go to Norfolk to see my mother who's in hospital, and I go to see my mother-in-law who sadly is dying in one of the hospices, and I see exactly the same signs. Yeah, and my point being is that there's clearly a national drive there for somebody to say, across all our healthcare providers, we need to push this because that's important. Will that still happen, or will that just be left to individual providers to decide what their clinical and public health within the wider environment, what their priorities are locally?
Okay, I'm not sure that the similarities that you're seeing are due to necessarily national directive. I think best practice is best practice, but also you've got to remember that lots of organisations are under the same regulation and inspection regime, and that's what people are looking at. We talk about LTHD going through an inspection at the moment. So I think part of that we are going to see. I can't see, however much local freedom that we are given, that the department is going to step away completely. We are always going to be in an environment where actually there's a degree of mandated endeavour within the NHS. That's how it works. And for some things they are good and some things they are bad, and hopefully the things that should be done at scale will continue to be done at scale and done better at scale. But those things where we need those local freedoms to be as good as we can be, hopefully we'll be given that permissiveness going forward. Only time will tell.
Thank you. Councillor Venner, do you want to come in?
I just had a few comments, some of which respond to some of what Councillor Lay said. So I sit on the West Yorkshire Partnership Board, which is the board that sits under the ICS board. So the Partnership Board is the leaders and Health and Wellbeing Board chairs from all 5 local authorities. And I mean, we've talked about the potential risk does seem to be around potential loss of focus on place, but there's also the neighbourhood health aspirations, which are a really good opportunity for councils and the third sector, and are obviously by definition about services being provided in individual places. I think, just to make a couple of specific comments, I think you referred to the possibility of SEND being moved into councils. I think you'll probably have had this as a really clear message from all councils. I mean, that would have to come with resource, because SEND is probably the biggest risk facing councils at the moment. It's certainly the biggest financial risk in terms of, you know, the cost of external residential placements for children with really complex SEND needs, the transport costs. I mean, we know it's an area where, we know we're not responding to EHCP requests in a timely manner. We're getting, we're still dealing with complaints from families. The idea of having more SEND work in councils, although it might belong there and be better done by us, it would need to come with resource attached, because it is probably one of the biggest financial risks facing councils at the moment. But I'm sure you've heard that many times. I think other risks that we identified in the Partnership Board, which I've also discussed with Victoria, are some of the health functions currently held in NHS England, like vaccinations and the mobilisation of work around vaccination and immunisations, prisoner health, dentistry. That pertains to the point Councillor Lay made about things being broken up. Like, I don't think we've got clarity really on where those things will sit. I think also I've got a question. I'd be really interested in your view of where you think health and wellbeing boards sit in this, if there's any change in the role. We've fed back nationally that, I mean, people have heard me say this before, so sorry that it's repetitive, but health and wellbeing boards, although they're a statutory requirement and they in theory deliver the health and wellbeing strategy for an area, they don't actually have any statutory power. They have convening power, and they can bring people together. But a lot of the work that happens is done on goodwill. So I know we fed back at things like the consultation the Association of Directors of Public Health are doing on health and wellbeing boards about the needs to be strengthened in legislation. So I'm just wondering, as things are at the moment, what's your view on where health and wellbeing boards sit in the new structure? Do you think their role is as it is now? Do you think it will change? Do you think they'll get any more powers that they can use to deliver health and wellbeing in areas? Thank you.
I'll take that, seeing that I've been present at the Health and Wellbeing Board since their inception. I think one of the things that's really interesting is that a Health and Wellbeing Board isn't a Health and Wellbeing Board, isn't a Health and Wellbeing Board. They are very different in different places. And without any change to legislation, there's inevitably going to be a need for health and wellbeing boards. I suggest that everything's still going to stay quite permissive, but I think the approach that we have had in Leeds is the right approach. And actually, when anyone from the outside comes and sees what we do in Leeds, they're often very jealous of the partnership that we have. So my view, because of that uncertainty, is that we should just press ahead and do what we know is right for the people of Leeds. And whatever the statutory responsibility may or may not be, Team Leeds is a real thing in Leeds, and we just need to capitalise on that.
Thanks for that, Jason. That's encouraging to hear. Okay, I'm going to now open up to any other questions or comments about what's been said or what you want on the work programme. The work programme is on page 129 of our current proposed work programme is on page 129 of the pack. So I'm going to start with Councillor Anderson. Thank you.
Yeah, I would just endorse what Victoria was saying about the drug and alcohol strategy that's at Exec Board tomorrow. So I think if we could monitor the priorities that are in there, that would be a good idea.
Thank you. Jane?
Yeah, I just wanted to, from a Health Watch perspective, flag that the items that people have raised that I thought are really crucial. I mean, absolutely, to hear from a carer's perspective, their experience of all the changes that are happening when they're trying to support people. I thought Sam could have been speaking for Health Watch actually when she was talking about having waiting lists with an equity lens and really looking at cost and value improvements that take place across all providers. And we constantly say at Health Watch, there are certain groups that get targeted by each individual organisation, but it piles on top of each other, so we really need to understand the whole picture, so that would be brilliant. Obviously the neighbourhood health is crucial. Very definitely support having sight of the improvements in place in response to the CQC maternity neonatal visit. And the thing that always comes up is primary care access. So it's good to hear that that's identified through the ICB. It's a mixture of both really positive and really negative experience. It seems to be very variable, so it would be good to understand that here at Scrutiny.
Thanks for that, Jane. And it's interesting because we talked about the waiting list for mental health access last year a little bit, and that point about equity and how do you prioritise it and how do you communicate that. So I think that's a really important aspect. So yeah, thanks for highlighting that again. Okay, Councillor Bromley.
Thank you, Chair. Sort of to second everything James has said, actually, but also adding in the toothbrushing in schools, I think that that's something that's brought up a lot by people, and also good to hear like the feedback from the CQC inspection, and also A&E waiting times was mentioned. I think in terms of that has had a lot of media attention in the past, and I think if making sure that we're aware of that's a crisis point often for physical and mental issues as well.
Yeah, thank you for that. And yeah, we did talk about A&E waiting times last year, didn't we? And the time that you sit in the ambulance outside A&E as well. And so I think that's a really good point. Thank you, Councillor Bromley. Okay, I'm going to bring in Councillor Gibson next.
Thank you very much, Chair. I'm going to chance my arm. I've been asking for this since I first got on the board back in 2018. Learning disability services, mental health services, specialist services for people with learning disabilities. I don't think we've ever had a close look at that. I don't know whether we need to be a sort of joint joint item with adult social care. Obviously, a lot of the funding comes from adult social services, but with my experience as a learning disability social worker, it's that link between specialist mental health services and the council function as well. And just want to reiterate what's already been said twice now around ethnicity and waiting lists, and the powerful speech that was done at NHS Confed Expo by Dr. I'm terrible at pronouncing names, and I'm going to pronounce it wrong again. Victor Adebowale, who was, and he talked about his experience and his mother's experience of unfortunately missing a cancer diagnosis. So, very important. Thank you.
Thank you very much, Councillor Gibson. If you don't mind, could you send that to me and Angela, and we'll get that video circulate around the board so we can watch it if you want to. And I don't think it'll be mandatory, but be encouraged. Good. Okay, I can't see. And new things. Yep, Councillor. Yeah. So, if anything you want to comment or bring up in the year ahead, so Councillor Ritchie.
Yeah, thank you. On a similar theme to Councillor Gibson on learning disabilities, the Being Me strategy, I think, runs out this year, doesn't it? It's got in its last year, I believe. So I think it'd be interesting to have some oversight of that. I think it's been extended, hasn't it, in previous years, but just making sure that that is still fit for purpose and is delivering on the objectives set in there. A lot of us have been to the People's Parliament takeover day today in the Chamber, and there are a lot of recurring themes year on year, still issues that don't seem to be getting resolved. So it might be time for a closer look at how we move forward with the Being Me strategy. And the second thing I'd like to bring to for a scrutiny inquiry is deaf-blind service provision in Leeds. I've sent the Chair some information around complaints that I've been made aware of, particularly around a lack of crisis support from we do have a commission provider in Leeds at the moment, and also some aspects of service delivery. So I'd like us to have a real inquiry where we bring in different partners to help perhaps shape future iterations of the products that we go out to commission, to make sure that it is fit for purpose, really, and maybe get some reassurance about the current provision. See if there needs to be improvements that can be made before that contract is up for renewal. And as I say, I think by getting in the right witnesses and making sure it's fully accessible with BSL interpreters for evidence giving and so on, I think that's something we can really shape going forward, that commissioned service, to make sure that it is fit for purpose and people who are deaf blind have full confidence in that service. So they're my two, the Being Me strategy and deaf blind provision. Thank you.
Thanks very much for that, Councillor Ritchie, and thanks for sharing the information you did before the meeting on that. And I think working with you to get the right witnesses would be helpful. I'm always a believer that these boards were added to when we hear outside voice, and I think that's something that I have tried to do, and so I'll be happy to work with you on that in particular. Good. And then I think Councillor Bromley wants to come in again.
I'm not sure if it's expecting the impossible with the amount of things that we'd like to cover, but I just wanted to go back to the active Leeds report and discussing the 3 pillars and the city's best ambition. We had a revisit to the national play sufficiency and strategy the other day, and I think that looking at possibility of can public health tie into the well-being of young people and communities on a local level when it comes to their play sufficiency and the accessibility to those kind of things within their local area and neighbourhoods.
Yeah, thank you very much for that, Councillor Bromley. Yeah, play sufficiency isn't meant to be just specifically targeting children. We all need well-being in our lives, whether that's like adults, we need to play. That might be organised sport or going to see an art gallery, but we all need to have time away from our sort of our work and stress stuff. So I think that's definitely a public health thing. So thanks for that. I can't see anyone else indicating. So I'd just firstly like to thank everyone for your thoughts and your considerations. Obviously, as Councillor Bomley said, we're going to struggle to get everything that we want in this year without basically staying here every day until the end of the municipal year. So what I will do is I'll go away and work with Angela and try and bring a schedule together. But we bring the work schedule to each meeting, so don't feel like it's fixed or it's unchangeable. So if you look at it and think, I'm not happy that this hasn't come through, or I prefer this to be linked to this item, it's very much it's not a fixed thing. So obviously next meeting is harder to change because you've got to give people time to write papers and get them prepared and finished in time to publish them. But after that, we'll be able to work to bring items in. So I just encourage you to keep that in your sights as we talk about it as the year goes on. And then just thanks again, our guest. I appreciate the thoughts and your comments you've made. Those have been helpful. Obviously, the board, we have to weigh a number of different things up as we decide what we look at, but we've definitely taken on board what you said, so I appreciate that. So with that, I'm going to close this item, and we're going to move on to the performance update item. I think our NHS colleagues are free to leave now. Thank you so much for your time and for coming today. But the performance update is across adult social care, public health and active lifestyle. So council officers, you're here for the next item as well. So I just stop talking for a minute while people change seats, and then we'll come back in a second. Great. Okay. So we've got two new people at the table. Do you want to introduce yourselves? I think I'll have to start with you, Tim, because Rob's car's not working yet.
There, I think that's working. Hi, Councillor, thank you. It's Tim Fielding. I'm Deputy Director of Public Health.
Yeah, and hi, I'm Rob Wood. I'm Head of Intelligence and Performance for Adults and Health.
Super, thank you very much. So this is the performance update. So as you'll be able to see from our new notes that we're getting, there's three distinct sections in this paper. So there's the public health, the adult social care and active lifestyles. And so I'm proposing that we do them separately just for ease of us staying in the right place at the right time. So we're going to start with public health, and that's pages 134, 135 and then 139 to 156. So I don't know, Victoria, if you want to make some introductory comments before we go into question.
Thank you, Chair. Yes, so I'm just going to make a few headline comments before happy to take questions on the report. The first one is just to remind the board what we try to do with this report in the way that it's set out. So we bring this report together, and the indicators that are new in the last 6 months, we provide particular commentary around. So the tables and charts in the appendices and the commentary on how we're doing against those indicators are particularly for the ones that are new and updated in this report. We don't get new data for everything, so we only comment on the ones that are new. And then what we try and do is pull out in the front end commentary of the report the headlines of the things that are going particularly well and the headlines of the things that are remaining quite challenging, just so it helps people to guide them through the data. One of the things we always do at the beginning, even though this time it isn't updated on new data, is just to remind people of the position in our life expectancy gap, because this is the kind of overarching health and health inequalities indicator. So you'll see in section 6 on page 134 that it's a reminder of the gap that we have in the city. And for the purposes of this report, the gap is described between the people in the poorest decile in what we call IMD1, Index of Multiple Deprivation 1, which is essentially a quarter of our adult population. It's the life expectancy for that group against the people in the most affluent decile of the city, which is a much smaller number of people. But so the headline is that it's a 10-year gap in men and a 9-year gap in women. Now that's when you compare those particular cohorts of people. You'll often hear us talk about a 12-year gap, which is between our ward with the highest life expectancy and our electoral ward with the lowest. So the ward gap is around 12 years. But for the way that the data's cut in this report, that's why there's a difference to that headline figure. But they're both correct. In terms of just pulling out a few improvements, the headlines that stood out from the latest cut of the data are, first of all, around smoking rates. We continue to show improvement on our smoking rate, which is really positive, although we do point out that we still have the challenge around the inequality gap around smoking. We have the data supports the fact that our drug and alcohol treatment continues to perform very well. The drug treatment completion rate shows continuous improvement, and even though we've gone down very, very slightly on our alcohol treatment completion rate, it's still incredibly strong, way above England and our comparators, and it's much improved on the trend over the last, well, certainly pre-COVID, over that last 5-6 year period. So we've highlighted drug and alcohol treatment as something that's continuing to improve. Obviously, we're never complacent on that. The third area to highlight is around children's healthy weight. We have seen improvements in this latest data, both at reception and in year 6. There's still a long way to go, but it's been very encouraging to see that the greatest improvement is in children from the poorest neighbourhoods, which is obviously what we want to see. So that gap is narrowing slightly, which is positive. And then lastly, we've not pulled it out in the front end of the paper, but just to bring the board's attention to the commentary around our suicide rate, which has fallen in this last period. So it's showing positive early signs of reduction, and this is against a national and regional picture, which is seeing suicide rates increase. So it's too early to say it's a trend at the moment, but we're watching that carefully. But it is early positive news around suicide rates in the city. Just to finish, the areas that we've highlighted as challenges, you'll see we've got a comment around we have persistent challenges on health inequalities across nearly every single outcome, and which is a consistent message that we give in this report. This is why we're doing the Marmot City work around fairer, healthier Leeds, and inequalities is woven into everything we do. So you'll see that gap across pretty much every outcome. Specifically with physical activity, whilst we are seeing an improvement overall in the rate of people physically active in the city, the improvement has happened in most affluent areas the most. So we are seeing a slight widening of inequalities around physical activity, even though the overall rate's gone up. So that's one to watch. And then finally, we've seen preventable deaths in people with serious and enduring mental illness have increased slightly. So again, that's something to flag with you as the board. So there's the highlights. Thank you, Chair.
I just wanted to add something on the obesity statistics, that although, as Victoria said, we've had a slight improvement this year, it's actually a really big improvement in comparison to what the national picture is, which is that it's worsening. So we're seen nationally still as having really good practice in this area. People, I might have mentioned this before, but we were profiled on the Today programme on Radio 4. No one will have heard it because it was at 7:20 in the morning on New Year's Eve. But it was Laura Kenny was guest editing, and she did a section on obesity because obviously her background's in athletics. And they profiled us in Leeds because it's still seen as a place that's got a really good news story. So they were specifically looking at what we're doing that's bucking the trend. So although our figures aren't where we would want them to be, they have gone up slightly, but actually in comparison to other areas, it's a really good picture and is being looked at by other areas. Thank you.
Thank you very much. Just a comment for me to start with that I know I mentioned this in Chair's brief, but I think having healthy life expectancy in here, if possible, would be a really good thing to look at, because I think it's an important statistic for us to look at. Okay, I'm going to bring in people who have indicated to speak, so I'm going to start with Councillor Blackburn.
Thanks, Chair. It's encouraging the reduction in smoking continues, but there's no mention about vaping there, and I mean on a different scrutiny board we looked at childhood vaping some time ago, and quite honestly, when I'm going home, I'll be stood at a bus stop and there'll be loads of people going in and getting vapes from there, and quite honestly, yes, it might be helpful for stop smoking, but I am concerned that there's people replacing smoking with vaping. I've got to say, when I gave up smoking, it was because I got COVID and it left me with a taste in my mouth. So that's one good thing that came out of COVID.
Do you want to comment on that, Victoria?
Yeah, thanks, Councillor Blackburn. Clearly we've got the tobacco and vaping bill that's going through National Parliament at the moment, and I think with great concern at the level of child and adolescent vaping in particular. We don't routinely get data in the way that we do on smoking on vaping currently, just because it's such a new. It's been a new phenomenon that hasn't kind of been, hit the systems of our data yet. But we do have kind of headline figures around proportion of children and young people that are vaping or have tried it or whatever. So, and it obviously is too high. Hence the support for the bill. I mean, clearly the message to adults who are trying to give up smoking is that vaping can be useful in that context. But the concern is much more about young people's uptake of. So we take the comment, Councillor Blackburn. I'm more than happy to share the data we have from the national work on percentages of vaping. But again, it's fairly limited and it's not that local. But we can share what we have with you. Thank you.
Thank you very much for that. And we actually talked about the NIST board as well. We did a piece of joint work with the Children's Scrutiny Board and what we'd like to happen. I think the point Victoria's made before, and correct me if I'm wrong, is that there's not the same data in terms of the absolute health damages of vaping compared to that of smoking, and that's may well be we don't have the data yet because it's newer, and so I think there's a time thing there. Victoria's not shaking her head, so that's good. Okay, I'm going to bring in Councillor Leahy next.
Yes, I'm afraid Councillor Blackburn and yourself has stole my thunder. As you know, I was very much involved in the children's vaping by bringing it to the Scrutiny Board. I now are going after adults. I have a lot of acquaintances who have never smoked, and yet there they are vaping. And my question was going to be the same as Councillor Blackburn's. Have we any data on adult vaping? Because there's no evidence that we're measuring it in the document.
So I think that's been answered, and I'll get Victoria to send a note. Yeah, perfect. Thank you. Okay, Councillor Buckley.
Yeah, thank you. What I'd like to ask is about the uptake on NHS health checks, and it's shown a decrease, although you say it still outperforms national and regional benchmarking. Do you know why has there been a decrease in the uptake of health checks? Is this a normal? I can't give the word I want. Yes, thank you. Yeah.
Thanks, Councillor. Yes and no. So what we always see every year, this is the quarterly data, so what we always see is a sort of steady fluctuation in the first 3 quarters of the year, and then a big increase in the final quarter of the year, where there's a big push, and that's where we get the big large majority. So we do always expect that. However, it is right that actually the first 3 quarters of this year have been lower slightly than we had on the last few years, and that is a surprise, and it is a bit disappointing. So we've been having this exact conversation between ourselves and with the providers, the GP Confederation and other partners about why that might be. We don't honestly know, I think is the honest answer. There's a lot of change in the system. It could be as much as just some of those practices. We do perform, as you say, at a very high level, considerably higher than the region, considerably higher than England. So it could just be that some practices have had some workforce issues, a couple of key members of staff off, and have just been slightly lower. There is a suggestion that some of the change in introduction of some of the blood testing facilities at the hospital has had a knock-on effect back onto primary care that might have impacted some of it, but it has had a slight impact. But as I say, it is around and about the same level that we would broadly expect, although it is slightly off. So it's certainly something we're looking at. The other thing to say is we've got some additional activity going on this year. So we've got the core contract, which is the one that's predominantly is what's reported here. But we've also been able to invest and undertake some exploration about how we can try and expand and trial some community models of delivery as well. So we're working very, very closely with them both about maintaining the sort of core level and keeping that at the right level, but also looking at trying some innovative sort of outreach community models as well to try and reach some of those areas and some of those populations which we know are sometimes underrepresented. The one thing that I will also say, just which I think is a real positive and continues to be the case, is we do target those populations that are most likely to benefit. So for health checks, there's 4 categories of population that we particularly target and we incentivise GPs to target, and that's people in the most deprived communities, because we know they disproportionately suffer from the health conditions, as Victoria's already mentioned, current smokers, those people that are obese, and ethnically diverse communities, because we know all of those have a higher risk of coronary vascular disease. And what we see is very high rates of uptake still in those communities. So well over half of our health checks end up being taken up by those populations, which is a real strength of our model that we have in Leeds. Thanks.
Thank you very much, Tim. Okay, I'm going to invite Councillor Ritchie to come in next.
Thank you, Chair. So welcoming the data on Year 6 obesity, I just wondered if you had some direct correlation with any initiatives that have been seen to work, an increase in activity in the group, rather than it being that, the worst case would be that actually people just haven't got enough to eat and it's a poverty issue. So can we correlate the improvements for the best reasons with anything?
I think for a very full answer, I shall take that back to my colleague who leads on children's health, and we can provide you with a full answer. I think my immediate answer is there's a whole load of stuff that we've done in the city for a very long time, For example, we have things like the Henry project around, which kicks in much earlier, but obviously sort of plays out in through primary school around supporting people around good nutrition for the very young. Plus a whole range of things that happen in our schools and communities that actually don't happen in other places. So, for example, in Leeds we still have a healthy schools programme that we fund through our public health resources. In most other places that doesn't exist anymore. So schools themselves, they're actually doing work around being a healthy school, being a healthy setting, and that will vary from school to school. There's a whole load of community public health activities that are funded in neighbourhoods for skate parks or local activities that, again, we support as a city that might not happen in other areas. So I'm sure if my colleague Catherine was here, she would talk about the whole package of kind of opportunities for children and young people to access, that it is stronger here than in other places. I mean, having said that, the general commentary, and I think it did come to the working group around healthy weight, is that the difference in how we're doing for the reception group of children is much more marked than year 6. And the narrative around that is that we're performing better on healthy weight in reception because of all of the very early years stuff that we do in the city, including breastfeeding, the breastfeeding support, and again things like the Henry programme. So whereas in the year 6 children, because they have more freedom around the food that they can choose and the places they can get it from, the challenge is really around making sure the environment is as supportive as possible for older children once they start making their own choices about food. So even though it is sort of tentative good news around the year 6 position, which I think flows through from the very strong reception provision, it starts to become much more difficult to sustain that once children become teenagers and start living in that environment that we know we need to do more about to support them to have healthy choices. So I'm kind of answering your question by saying what the challenge is at that age, as well as what some of the positive things are. But it has focused our work much more on the healthy food environment as something very important, because we're seeing that difference eroding as children get older. I hope that helps, Councillor Ritchie. I can certainly get more detail from my colleague on the range of interventions that are around for year 6.
Yeah, Councillor Ritchie, do you have a
Yeah, it does help. I mean, all those things we've had, haven't we? It's really saying, well, this has changed this year. So in more deprived people, children from deprived areas are actually doing more sport, for example, would be one example this year. We know the cost of living is affecting families, and that's just my worry that is having an effect. But yeah, I'm aware of the full sort of offer in Leeds. But can we say that it's this that's working, kind of thing?
And I think what you're saying is you'll give us a fuller report in the near future.
I can do that with my colleague Catherine. Yeah, I think if I can just add a comment, I think the fact that we're seeing the reduction mostly to a greater extent in our more deprived communities, both at reception and year 6, is a result of our targeted approach to our interventions and services across the city. So again, that's something that isn't playing out in other areas, which is different for Leeds. So again, it's partly what the offer is, but there's something about how that is targeted towards the communities that need it most, which seems to be giving us those positive results. Thank you.
Yeah, thank you. But I think the point Councillor Ritchie makes about assurance that it's not people being hungry is really important. Councillor Taylor, do you want to come in on this point?
Yeah, I was going to highlight what Councillor Ritchie says, but just a little bit of it. I just think we need to keep an eye on it. At the moment, I'm watching Coronation Street with a storyline with 2 young children. they're not eating at home, but they're going out and eat with next door neighbors. The parent can't afford those to feed, so they're dropping them here and there, and they're getting a nourishing meal from someone else. So is it what's going on in the deprived community? Because here, 6 kids are bright kids who can walk from house to house. Are they picking up a proper nutrition food where they are going? I agree they are more older to get active, but we do need to keep a minded eyes to see where they're getting the nourishing food from, and will it fall back if it's not from their own parents.
Thank you, Councillor Taylor. I'm going to take that as a comment, I think, because you're absolutely right. That's yeah, I agree with you. Thank you. Okay, Councillor Gibson next.
Thank you, Chair. It's largely been said around vaping. I'll just add that as a very occasional smoker, like festival smoker turned more regular vapor, the amount of chest infections that I had was unbelievable. They're terrible, so we should keep a track on it. They are better than smoking, yes, but they're certainly not good for you. Let's put it that way. The only thing that the only thing I wanted to raise is nicotine pouches. We've seen, hopefully we'll see a reduction in the amount of young people using vapes now that the disposable vapes have been banned. I still see them advertised, still see them being sold, unfortunately, in shops. It's a £200 ban for anybody caught initially, which it doesn't put people off. Obviously, it's more serious after that, but people are chancing their arms. But obviously, as they do get sold, hopefully we'll start to see a reduction. But typically, we're starting to see another phenomenon, which is the rise of young people using nicotine pouches. And these nicotine pouches, again, I use. I know I've gone from vaping to nicotine pouches. I really do just need to quit nicotine. But anyway, that's another discussion. They are, you can sell them to young people completely legally. There is no age restriction on them, and they do not feature, as it stands as well, in the tobacco and vapes bill. So whether or not we need to write to whoever's putting that together, I don't know, or whether we need to keep a track on it, because it's the next thing coming around the corner, and you can see the prevalence of that spiking massively as we see less vapes being sold.
Thank you. Councillor Bennett, do you want to comment?
Thank you. It's really interesting that you've raised that, because when we had the discussion, I don't know if people remember, when we had the discussion here about vaping, we did talk about how powerful the tobacco industry is. Obviously, it's a multi-million-pound global industry, and your colleague who leads on this area did say once we get on top of vaping, there will be something else. The industry will come up with something else, because obviously their reason for existence is to make a profit out of selling nicotine-based products which are addictive. So it is really interesting to get that feedback. That might be the next thing, because our expectation is there will be a next thing that will have to be combated once we've managed to do away with vaping. Thank you.
Thank you. Councillor Howard, do you want to come in on this?
Yeah, I was just going to say, with regards to those pouches, they're actually handing them out for free in Leeds city centre, like they do with Coke Zero and things. So they're not checking anybody's age, they're just handing them out. They're all bright coloured packets, tropical, like the vapes, tropical flavours. But the other night, they were actually going from bar to bar, handing them out to people drinking, which I know, it's 18, it's fine, but I got some for Councillor Gibson because I know he likes them. And one of the packets he said was actually a very strong nicotine level. So it's not even they're trying to use them to reduce smoking like vapes were supposed to be used in the first place. They're just giving these things out in the streets, so it does need something looked at.
Yeah, thank you. And with Councillor Venner being here, sitting on the Health and Wellbeing Board, I'm sure she will bear that in mind. Okay, I'm going to move it on now to Jane. Do you have your question?
Thank you. I'm conscious of time. It's more a statement, really. First, thank you for the report. I always enjoy looking at it. You introduced it by pointing out still the challenges of still having a significant gap, inequality gap, and I would say, yeah, I mean, after so many years, despite the absolute passion and commitment and the city ambition to address the inequalities, we're still not achieving it.
and kind of depressing really, but also to focus specifically on earlier conversations about childhood obesity, but also adult obesity and the consequences that has on health. So looking at the difference, I think it's 10% difference between the most and least deprived in terms of obesity in adults. And in children, year 6, it's 15% difference. So it's a growing problem, and if you pan that out, you can see then the potential health consequences in terms of more diabetes, more cardiovascular disease, etc. So I guess, yeah, it's good that it looks like there's an improvement around childhood obesity, because we need it.
Thank you very much for that, Jen. Yes, I'm going to take that as a comment, which it is. So thanks for that. But you're right. There is we've got to try and be positive about the future, but a lot of work has gone into something, and it's not necessarily got all the answers that we want yet. Okay, I can't see anyone else indicating on this section, so we're going to move on to adult social care, which is pages 135, 136, and I guess the main indicators are 157 to 163. Caroline, do you want to make some introductory comments?
Thank you very much, Councillor Scopes. Yes. So the adult social care part of this report provides a bit of an update on our adult social care activity levels, and they are provisional results at this stage for the year 24-25. And as of the 31st of March 2025, adult social care has been providing long-term support to just under 8,000 people, and that is quite a decrease in the numbers compared to the previous year, so a 9% decrease. And we think this is a combination of some of the work we've been doing around older people's services around the Home First programme and the success of that Home First programme, but equally some of it is about data cleansing as well. So, mindful that we treat some of these figures with caution. What you'll see in the report is that we continue to see quite significant pressure across adult social care, particularly around demand, numbers of people requiring care and support, particularly working age adults and ageing population as well, people with learning disabilities of an older age group, for example, people with mental health needs of an older age group as well. And the complexity of need continues to be quite high, and we're seeing that trend, and this is a national trend, not just a local one. Our provisional results then, going on to the ASCOF measures, are showing an improvement, quite a significant improvement in 12 of the measures. 12 have improved whilst 2 have declined in terms of our performance, and the rest we're still waiting for the final results. But what we do see is that the way in which we've been working recently, particularly around putting more staffing capacity in, more social workers and more occupational therapists, changing the way in which we work as well, has resulted in quite a significant improvement on the numbers of people waiting for an assessment and the amount of time that they wait as well. Both of those indicators improving, and that's been some of the work that we've been doing around the CQC assurance, just getting ready for that, and we've put a really strong implementation plan, action plan to try and improve that, and that is bearing some really positive results. So in terms of reduced waiting lists and waiting times, the number of people waiting for an assessment has decreased by 28% between March 2024 and March 2025, and the number of people waiting, the amount of time they're waiting has also reduced over that same period. So we're really, really pleased with the progress that we're making. Still a lot more to do. We've still got too many people waiting for an assessment, but our activity is really helping with that. In terms of our 2 surveys that we do. The provisional results from our personal social services survey shows again improvements in 5 of the 6 available measures, which we're really pleased about. Most significant improvement being about the proportion of people who use services who report that they've got control over their daily lives, increasing from 70.9% to 78.2%. So again, really pleased with the outcome of that. With regards to carers, there is an improvement, but it's slow and small, but it's going in the right direction. And again, we continue to focus around improving the numbers of people that are carers that receive an assessment, and the numbers of carers that are offered a direct payment as well. So we do still see some challenges, particularly our move around direct payments continues to be quite stubborn. As many people that are newly getting a direct payment, we're seeing a drop-off, so our numbers are quite low and quite stable. But again, we've got a whole improvement plan against that, and you will have seen that we brought that to Scrutiny Board last year around the work we're doing around that. We've also seen a reduction in the number of people that are using telecare, and we are worried about that because that's one way of promoting people's independence without the need for formal care and support. So again, we're doing quite a lot around marketing and demonstrating why and how telecare can be beneficial to people. But we think this is perhaps linked to our charging, because our charging did increase. However, we still benchmark quite low in terms of the charges we levy for telecare. And when you balance the charge that people might pay for telecare compared to how much they might have to contribute for a home care package, it still really offers good value to people. So we hope that we will make some inroads into improving on the use of telecare across the city. That's about all I wanted to give in terms of highlights, but very happy to take questions. We've got Rob here who can help with some more detailed questions as well.
Thank you very much. So open up to questions. Does anyone have any questions? I'll start with Jane. If anyone else wants to, please indicate.
Hi, Caroline. I've got 2 questions. One is about the direct payments. As you said, you brought the plan, the improvement plan. Is there any reason it's not picking up, and have you got any kind of insight in relation to that? That's the first question. And the second one is, have you any qualitative information about why people are not picking up telecare? Maybe they prefer the human contact of a care package rather than the digital telecare package.
Thank you very much, Jane. So in terms of the direct payments, I think that we would readily accept that our processes are really clunky. It takes quite a long time for social workers to be able to set up a direct payment. And people know that, well, if I had the choice of a wait of 6, 8, 10 weeks to get a direct payment set up relative to getting a home care provider, which is now only taking 5 days to sort out, I'd rather have the home care, please. So we recognise it takes a while. We have looked at changing how we work with people who might be interested in a direct payment, so that the time taken to get a PA, employ a PA, identify a PA, a personal assistant, that is, sorry, and also the process of setting up the direct payment, including not needing to have a bank account, but having a prepaid card. Really trying to simplify the processes. We're hoping that will bear some fruit. At this moment in time, we've not seen that, but we've also changed the function. So it previously was sitting as work that every single social worker in every single team did, but we've created a direct payments central team, which is beginning to gain some experience and some expertise, and goes out and supports people directly in pretty quickly, so that it's not on a list of to-do things for a very busy social worker who knows that it's going to take too long, but it's actually a specialist team that's picking it up. So we hope that those measures are going to help us to see some improvements in direct payments. Again, I check how this is going with other local authority areas, and even those local authority areas that were really doing very well around direct payments have seen a significant drop. So, and as the home care market particularly has become more and more buoyant across the country, because it's so much easier just to get an agency to provide home care compared to a PA, a lot of local authorities are seeing a reduction in the numbers of people having a direct payment. But we know that it's a really good offer for some people, so we want to, even if the numbers are low, we want to make sure that we target certain groups who might benefit from it. People with learning disabilities, for example, people with who are living in ethnically diverse communities might find a local person rather than going to an agency, having a much more personalised approach. So we're doing a little bit of targeted work, including also with carers as well. So fingers crossed we'll begin to see some improvement. Did you want to come back on that before I answer the...
It might be a naive question. In relation to the being able to use an agency or wait a long time for the direct payment, can you not kind of dual run? Can you not have an agency come in while you're sorting out your direct payment?
We can and we do. We do offer that as an option. But what we know is very, very quickly people settle into whatever they've been offered, and then, we've missed the opportunity. So yes, we do try and do that, because we don't want people to wait. If they've got a care need, if assessed as needing a care package, we won't wait because their needs are really, necessary. So we get on with it, but sometimes it just defeats the point of then going and putting a package in place. In terms of any qualitative information on telecare, apart from just knowing that people are saying, well, the hike in the cost of it has prevented people taking it up, we don't have any more information. One of the things that we've piloted, though, in our reablement service is that we've offered it to people free of charge. So people who go through a short-term following a hospital admission, they're going home, we give them an in-house reablement service. We're trialling putting in telecare, not charging them for those few weeks that they're receiving that reablement service, with a view to seeing if people are then willing to continue to have telecare when their package then gets placed with an external home care agency on a longer term basis. And that's proved successful, that pilot. It's been small in number, but people have said, well, actually, we find this really useful. It gives family peace of mind, and therefore they're willing to pay to have the telecare. Telecare doesn't replace the need for home care agencies to provide care. It's an added extra. So we don't think that people are saying, well, I don't want telecare because I want that human contact. It's not an either or. Often it's part of the wider package as well.
Thank you very much. Okay, I'm going to bring in Councillor Ritchie next.
Thank you. Two things from me. The welcome reduction in assessment weights is great. I just wondered, and you talk about the investment that's gone into staffing around that, and that's for care packages and what have you, care assessments. I just wondered if you knew, I may be straying into other scrutiny boards here, but in terms of housing assessments, again, often OTs will make recommendations, but it does link in to health and well-being, I would say, because getting, say, adaptations right or suitable housing is really important. So have we had the same reduction in waiting times for assessments around housing, specific housing assessments? Do you know? That's one question. As I say, I recognise it might be straying into other boards. And then the other thing is onto workforce. And I just wondered if you expect any effects around challenges due to the government's changes to the immigration rules, whereby they've increased the minimum salary before you can sponsor or bring in overseas workers. It may be seen as an opportunity, but I can see it being a challenge, and I'm aware through some organisations that it is already proving to be. Thank you.
Thank you very much, Councillor Ritchie. So in terms of housing related assessments of need, we would have to go back and just check with our housing colleagues whether there's been any changes. We certainly know that by introducing 2 housing officers into our transfer of care hub, people in hospital waiting to go back home, that's improved considerably. So that initiative really has helped and really has worked, and we're looking at introducing the same concept for people that are in LYPFT, mental health sort of hospital placement, looking at whether their discharge processes can be speeded up as well by having housing officers involved in that discharge pathway. So we know that that's worked, but overall people particularly at home already requiring housing assessments, housing adaptations. I don't know the details because that will sit with occupational therapy staff that sit in the housing department and directorate, but we could find out. We could look for that information and find out if that's helpful. In terms of the changes in immigration rules, international recruitment, we've been fortunate in Leeds in that we've got a really buoyant home care market now, and that's partly due to the fees we've been paying to our home care providers and our real emphasis on paying the real living wage, and that being passed to the workforce has meant that our home care providers haven't struggled hugely to recruit locally based staff. What we found, though, conversely, was that there had been quite a significant increase in the numbers of care workers coming in to Leeds and working in Leeds or being invited in by home care agencies popping up left, right and centre in the Leeds area because of our attractive relatively attractive fee levels, setting up as home care agencies, getting international recruitment and getting the workforce, and then not being able to give them sufficient work, and actually a lot of sort of exploitation of care workers that have been coming with their and those home care agencies then having their visa, their sponsorships revocated because of that sort of less scrupulous and exploitative practice. And what we were finding, and we're still finding, quite a lot of displaced care workers. They've been brought into the country on the promise of enough hours of home care employment, and then they've not been able to give them the work, and those workers are looking for other work. So we've had to do a huge amount of work locally to support those displaced workers and try to match them with good home care agencies. So to some extent, the change in the immigration rules are going to be helpful in terms of reducing that exploitation. And at this moment in time, we haven't got and we haven't heard care providers, be it home care providers or care homes, saying we are now going to have problems recruiting adequate levels of workers from local area. We'll just have to keep an eye on it. We'll just monitor this all the time.
Yeah, thanks for that, Caroline. So, Councillor Ritchie, there was the housing, absolutely right to bring that up, and we talk about that marmot type, wider determinants of health, so I fully support that question. And then in terms of the exploitation stuff, I think we had a briefing a few years back on this item, so I'll see if I can find that and share that again, because I think there may have been one provider that we had a particular issue with, but hopefully Caroline's right that is less of an issue now. Okay, Councillor Bromley.
A couple of things Caroline's already addressed actually, but in terms of it's pleasing to hear the changes with the direct payment team and being localised and gaining more experience with that. Just checking then that we're being transparent with people waiting on those direct payments and the length of time that it will take for that. And just a second question too, in terms of the what was the other subject that we discussed? I should have wrote that down. I'll come back on that. I'll remember in a minute.
So the answer is absolutely yes. Right from the get-go, when we receive referrals, we tell people straight away how long they're going to have to wait for an assessment. And we're able to do that now really well and really quickly, so at the point of a referral, and then subsequently once they've had the assessment, when a package is being sourced, we tell them how long it's going to take if it's an agency providing the care or if it's going to be a direct payment. So they're absolutely told, and probably more in detail now and more precisely than we've ever been able to before.
Thank you, Caroline. And then with the telecare, do you think that, I assume that we put up the price only because it was deemed as necessary, but would it be possible, and is it part of a discussion of whether reducing it back to where it was before, if that maybe is part of the problem or the blockage in uptake? And also, as part of that, are we finding that it's people that did receive it before that have dropped it since the price change, or are we literally talking uptake?
So we wouldn't reverse the decision because we've got a savings target in terms of income generation around telecare, and as I said earlier, we're still lower in our charge relative to our neighbours. But what we are looking at, and as I mentioned, this trial that we've done around offering it free of charge for the first 6 weeks while somebody gets the reablement, we can see that might be beneficial, and that might incite people to say, okay, well, I'm willing to give it a go if I don't have to pay for it for the first few weeks, and then implement the charge. We'd have to be very, very upfront that it would be time limited, and they can then make the decision of whether it works for them or not. So we will want to do that. And in terms of the question around what has caused the drop, is it existing people using it or new? It's both. It's a mixture of both. So, and again, we're hoping that different measures and the way in which we sort of approach this and sell the benefits that telecare can bring to people, it might encourage more people to take it up.
Thank you, Caroline. Okay, Councillor Lay.
Thanks, Chair. Yeah, funnily enough, I was going to talk about telecare. I think both my father-in-law and my mother have sent their telecare back, one from Leeds and one from Norfolk, both complaining about price, but both neither getting the understanding that it's an insurance policy in much the same way that they have house insurance in case of fire. They might never need it, but it's an insurance policy. Neither gets any formal caring from statutory bodies, so if they end up on the floor, they're on the floor. There's no one coming in because there's 2 carers a day or Meals on Wheels or whatever. So it is a concern, and I suspect both of my parents are not unusual. More work to be done. Other thing, social worker access. It's just in the last couple of weeks, really, I've picked up 2 pieces of casework. One about concerns, and I'm going to bring them to you outside this meeting, about concerns about the length of time it's taking to be assigned a social worker. So, like I say, so that remains a concern. But really, what I wanted to ask about is direct payments. I've never understood direct payments. So, in as much as when you say you can have a personal assistant, does that mean that if it was me, I'm trying to work it out so I understand it for the whole of the year, because we will come back to this a lot, I suspect, in adult social services. So you give me some money and say, do what you want with it. Can I go out and literally choose anybody? Is there any scrutiny? Is there any oversight? Is there any protections for the individual? If I do go out and Kevin becomes my carer and I start chucking him money on a weekly basis and say, you come and do my hair and wash me and whatever, when he goes sick or he can't do the job, what happens? So do they have to be part of a recognised agency or a company, or can you just give money to an individual?
Thank you. So there are some broad brush rules around the use of direct payments to protect the person that is requiring the care and support. Yes, a person can just ask a friend, a neighbour, if they would be willing to provide the care and support, and they pay them, but they are encouraged to employ them. They have to pay all of the sort of sickness pay and all that sort of stuff. So there's a formal process of setting up a direct payment when you use somebody of your choice through a personal assistant. We have internally within the directorate, we have a small team who works with people who to have a direct payment, who employ a PA to do just that, to try and match people to people that they might not know but want a PA, and put in all the safety processes. The other thing that happens also is that we have externally, because we can't do this internally because it's a conflict of interest, we externally commission an agency to do the bank accounts and the payments for that employment of that care worker, that PA. So that is outside of us. So basically we're paying an individual, but that individual gets supported through this payroll direct payments support service to pay the care worker. So the money isn't switching hands. The person needing the care doesn't pay the care worker directly. It happens through a very clear process. We also look at sort of prepaid cards. So there's oversight on how an individual is using their allocated budget, so that they're not spending the money in the pub, which is often something that people say, well, how do you know that that person is using that money for, their care and support needs? So there are very clear sort of security measures to keep the person safe and to ensure that the funding is being used for the right purposes. I hope that helps.
Thanks for that, Caroline. I'm just going to make a comment on the telematics thing. So a friend of mine recently got a telematics. It's because her family were worried about her. And she wears it as an insurance policy, like you said, Councillor Lay. And I guess there's a concern in my mind around health equalities here. So if you've got a family who can pay for it, you've got a better insurance policy than if you don't. And and I guess that's just a worry. It's not a question, it's a comment. I can't see anyone else indicating on this section, so we're going to move on to active lifestyle. So this is page 137 and pages 164 to 170. Jane's arrived now, so do you want to introduce yourself and then pass on to Steve if you want to make any introductory comments, Steve?
Thank you, Chair. I'm Jane Wallen. I'm the Chief Officer for Active Leeds Operations and Culture in City Development. And the active lifestyles team, which the majority of this paper covers, are a really important part of our communities work and our engagement work with all of our residents across the city. It's a really powerful tool that we use across the city, and the team work incredibly hard to deliver the programmes that we have in partnership with NHS, Public Health and others, ICB. So I'll hand over to Steve and he can talk you through the work that we're doing.
Thank you, Jane. Obviously this kind of report is kind of highlighting our kind of inactivity rates, which is reported through from Sport England as part of their Active Lives survey. Unfortunately for this period, inactivity rates have increased, from November 23 to November 24. However, we are still performing well nationally and regionally, and above averages on that side of things. There's also a caveat around the kind of data that we kind of get from Sport England once it's kind of broken down to a local authority level, just because the sample size is relatively small, where you're looking at 1,000 people who are surveyed across the whole of Leeds, to kind of give this indicator a score. And obviously, as Victoria kind of highlighted, in terms of the public health kind of measure, that activity levels actually have increased across Leeds. And a lot of our data that we kind of hold from a central basis as well also indicates that activity levels are increasing, from our kind of health and fitness memberships to our swim lesson programs to our gymnastics programs, across the board in terms of that side of things, and just in terms of overall kind of patronage, has seen a massive increase from COVID times by about 20% as well. So although the indicator kind of just highlight that, our own kind of internal data is probably not highlighting that, and I have pulled together a bit of a slide which we can share after this meeting in terms of some of that data, highlighting that side of things as well. But the biggest impact for us especially is just in terms of the deprivation gap, in terms of, like, again, Victoria highlighted that unfortunately people in more affluent areas are still kind of taking part in physical activity more, and that is growing, but from a deprivation kind of community level, that's where we're just seeing that growth not as increased as quite as much. However, we still continue to work on our resources with partners and stakeholders and the communities themselves, and through our kind of place-based kind of work, we are seeing huge impacts on that from a day-to-day basis. As James kind of highlighted, there's really attached value in terms of all that work. The board did kind of ask for a bit more detail in terms of our disability work that we've had, so that's also been included in the report this time, amongst all our other data in terms of just working with children and young people, older people, our health programme side of things as well, which also kind of highlights that we are making progress on activity levels, even if that's not highlighted in this survey as such. And I'll leave it there for questioning. Thank you, Chair.
Thanks, Steve. Just a quick question of clarity. So on page 164 at the top, there's a table. Hopefully you can see that. It says percentage of physically active adults. Is that inactive adults in that table?
Yes, that's inactivity levels that we kind of focus on. So that's probably an error in that report.
Thanks for that, Steve. That's helpful. Have we got questions from board members? I'll start with Councillor Bromley.
Hi, thank you for that. In terms of, have we noticed that it's post-COVID that there's been more difficulty in uptake and addressing and sort of accessibility in how we're working with local people, or is this something that has always been sort of an aim and a measure that's still in the making of how we measure its success?
Yeah, I'll be honest, it's always been there and always been a challenge from our kind of sector in terms of how we do engage and bring in that accessibility side of things. But since COVID, we've probably actually seen the opposite effect, that we are seeing more people from deprived wards accessing our kind of services. They kind of range from, again, have increased from 3% in certain localities up to kind of 15% increase in terms of the deprivation levels that people are coming from and using our facilities on that front. And a lot more impactful work in terms of our communities and, again, understanding what their needs are. Previously to that, before COVID and the lights, we probably used to go in there with knowing what we think is best for the communities in terms of delivering activities for 12 weeks and then stopping and then expecting them to continue on that front, as kind of funding is kind of short term in terms of that way. But through the new kind of funding with Sport England, it is very much that longer term kind of effect and really working in those kind of places that need extra support, but collaborating with the communities themselves to understand what are the issues, what can we support with, but also a lot broader than just diving in there with activities. you've got to look at the surroundings, the environment, how easy it is for people to actually just move a little bit more. And especially from our side of things, it is a lot more than just sport and activity based. It is more that just encouraging people to get up and move, no matter what they do on that front, whether that's kind of just walking to the next bus stop or walking to the green space park area, or the like. So again, it's just looking a lot wider than just purely kind of old school kind of physical activity kind of interventions, really.
Super, thank you. Do you have a supplementary? Yep.
I just wondered if we also have a reference to other cities that are maybe have or deemed to have really good public transport, and their inner cities have been led further away from cars and more towards pedestrianisation and bike use, and whether our measures with that in terms of active lifestyles has made a difference, and if it's something that we can then use as a measure for us as well.
Yes, as part of our kind of Department for Transport kind of pilot scheme that we have in terms of social prescribing, active travel side of things, we kind of work with Department for Transport to learn from other areas and what we can do differently, but also what we're actually doing well at as well. Obviously, in terms of the kind of geographical kind of areas, there's certain cities that are more geared towards kind of flatter kind of elements where it's easier to get around and move around, and obviously in terms of the kind of volume of the city and the size of the city as well, in terms of that side of things, it all has an environment kind of impact as well. So we do kind of learn from others on that front, and we have implemented a number of different things that have worked. Obviously, from a city perspective, there's been huge changes in terms of the modal change, in terms of encouraging more people to be able to walk and cycle and wheel in general terms. So again, that kind of work, we work now a lot closer with all our kind of highways and transport team to kind of plan that out, but also the travel behaviour team, just to make sure that those impacts in terms of that active travel side of things is being heard of, not just around the infrastructure. It's a lot more there in terms of building up confidence. Safety is obviously a number one kind of area that they kind of pick up on as well. So those kind of things, again, is a lot more than just an intervention kind of principle.
Jane, do you want to come in and then?
Yeah, I think just to add on to Steve's comments there, I think it's really important to note that actually from an exemplar point of view and the work that we're doing around Vision Zero, the work that the Highways and Transport team have done around their transport strategy and the conversation around active lifestyles and the infrastructure that we've put in over the different phases of the active travel network and through the LP-TIP programme with the city centre and wider corridors. Actually, a lot of people come to talk to us because of the work that we've done and how we've implemented the infrastructure changes. I think the social prescribing project is probably one worth sharing back with this scrutiny board, because it's in almost its last year now of review, and it's done a lot of really positive engagement work and infrastructure considerations around actually how can we make local networks and make local routes easier for people in the Bermontoft, Skipton and Hare Hills communities. So there's some really good work that's gone in. The question for us now is what do we do with it and how do we move it forward? Because we don't want this to be a stopping point for us. So we've had an internal discussion in our directorate around embedding this in localities and the locality working and neighbourhood networks, and how can we continue something that was seen as a national exemplar, and we were given 1.3 million from the DFT to celebrate Leeds and the work that we've done previously. How do we continue it and how do we move it forward, which is really, really powerful for us as a narrative. So I think we can come and share that work with you, but also we're now starting to think beyond it, which is really important.
I'd really welcome bringing that report back with our long list of other things to focus on, but yeah, significantly important. Thank you.
Thanks, Councillor. Okay, bring in Councillor Buckley next.
Yeah, thank you. I'm referring to page 137, item number 19. I've read this about Sport England and the social value of sport, saying the annual social value is 107.2 billion. And then on the line below, it gives a figure which is that billion or million, because just after that you say this relates to post-16-year-olds. What does this actually all mean? How do you calculate these figures?
Yeah, so the figure below reports to the Leeds specific area, whereas the kind of 107 billion kind of reports to kind of the national kind of picture in terms of social value. So Sport England work with the Sheffield Hallam University to kind of coordinate the social value of sport. So things such as obviously the reduction of people going to healthcare through being active, people kind of reducing social isolation, people and having an effect on crime, and all those kind of measures that we know physical activity can contribute to and play a part of, including education and attainment and those type of things. So they're all built in a kind of robust kind of calculation in terms of that side of things, and Sheffield Hallam kind of lead the work around social value, and that's all the different measures that kind of come into that side. And yeah, the Leeds specific breakdown is 1.3 billion. Not sure why that's kind of written out, unlike the top one. So we'll pick that up next time.
Super, thank you. Okay, Councillor Ritchie.
Thank you, Chair. It's more of a comment, and it's just to highlight the activity gap for disabled people at 10.9 billion. And I wouldn't. Well, it is a bit of a question. Sport England. I did. It's a while since I'd read that report when it came out. Could you just remind us what they're going to do to address that? So I presume more income for local authorities to deliver our programme. And just before you do answer, so you're keen to respond. Again, at today's Chamber Takeover Day, quite a number of questions were raised about sport opportunities in Leeds, and I was sat there. There were no one officer-wise to answer the question there, but I was sat there thinking about the report you'd sent me, thinking there are opportunities out there. People clearly don't know them, so again, getting that word out with groups and what have you would be a good idea. Thank you.
Yeah, in terms of the kind of Sport England side of things, in terms of that report, it isn't becoming just on this disability side of things for us in terms of the funding that we will see, but we will have an angle proportion towards the disability side of things in terms of our place-based work that we're kind of putting a funding application for at the minute. So that'll be all brought into it. It's just they don't have different pots for different things. They just have one kind of pot that they're kind of currently working on. Although the chief exec, there has been a bit of a change around at Sporting, so where are those and any of that changes in the future? But yeah, from our side of things, as part of our application, we will be including a disability kind of angle as part of our kind of funding bid that we put in there on that front. So we'll be able to continue a lot of our good work that we're doing, but hopefully branch it out to a few more different areas as well. In terms of promotion-wise of all the good stuff, yeah, it's always a challenge for us to kind of increase that awareness and across the board. So we'll continue to do that, and yeah, make sure that if there are groups we're missing, that we kind of work with yourselves and understand that and make sure we've got representation there as well.
Thank you. Okay, Councillor Lay.
Just a quick one, Steve. In a session where we've really talked about marginal gains and equally marginal losses, the one bit I just wondered about was page 165. We've had 947 referrals for rehab, which is a 73% increase. In moderate, I assume that means physical activity, does it, PA? Have you got a new physio, or, what's happened? Because everything else is percentage points, small singular, and this is 73%. I'm just interested, that's all.
Yeah, so that's just showing in terms of the impact it's having, in terms of the programs we deliver on, is really showing that it has a huge impact in terms of improving physical activity, especially through the kind of cardiac rehab side of things, and giving people the confidence to be able to, they can safely do activity as well. There's a lot around that side of things in terms of cardiac rehab, because people think because they've got that particular long-term health condition that they can't do exercise. So once they come into the program, then there's more that they can do quite quickly. So people build up that confidence a lot quicker, and that has a huge impact in terms of making sure that they are then more physically active as quickly as possible throughout that kind of program. So that's where a lot of that kind of comes back from, but it's just highlighting again the impact that these kind of programs do have, and hopefully in terms of moving towards that prevention kind of model, that we can really show again that we can actually reduce those people having to come to us in the first place, is where we want to get to. But obviously once they do come to us, we do have that impact on them.
Yeah, I think I misunderstood it. Actually, now you've explained it. I thought you'd gone from having 100 referrals to 947. But what you're actually saying, of those 947, nearly 3/4 were given the confidence to do moderate activity rather than minimal activity, and that obviously helps with their cardiac health, respiratory health, etc. Thank you.
Thank you for that, and thanks for that clarification. That is helpful. Okay, I can't see anyone else indicating, so I'm going to move on from this item. So thank you very much for that. That's been really helpful. Thank you for the work you do through the year, not just the performance report that you come here. Okay, I'm going to move on to item 11. So item 11, we had a working group, and you've been circulated the note. What I don't want to do is get into the debate about this again, but I guess this is meant to be a reflection of the discussion that we had. So if you don't think it was a reflection of discussion, or there's something specific you think should be in there or isn't in there, or isn't there that shouldn't, please indicate. Otherwise I think it's about approving this, because rehashing this conversation isn't what the plan is right now. If you're quiet, I'm going to assume everyone's happy with it. But it's important because it'll now be documented as on the public record as the discussion that we had. Okay, so we are happy with that. Great, thank you. Okay, and then moving on to item 12, which is the date of the next meeting. As you know, the next meeting will be on Tuesday the 15th of July at 1:30 with a pre-meeting for members at 1 o'clock. And all the meeting dates should now be in your diary. So thank you very much. And I'm going to formally close this meeting. Thank you.